My name is Faisal Alharbi, and today I'm going to talk about BUK topic review and case presentation. This presentation was supervised by the Dr. Nada, anterior segment fellow, and Dr. Adel, anterior segment consultant. So today's topic is going to be BUK topic review and case presentation. So for the outline, first I'm going to talk about a case presentation about a case we managed here in GHA, and then an overview of BUK. So for the case presentation, this is a 93-year-old lady, known case of hypothyroidism and hypertension. Patient was referred as a case of cataract and climatic traumatic keratopathy and was referred to the anterior segment clinic. She was complaining of right eye pain, tearing, and foreign body sensation. And upon further history taking, patient denied wearing any contact lens, any previous infection like HSV and Varicella zoster keratitis, or any connective tissue disease, IBD, or any ocular surgery, or any systematic disease other than epigastric pain in which he was followed with family. So for general examination, patient had a normal general examination, no sudden node deformity, which might indicate any connective tissue disease, deformed auricular or normal skin, and normal skin with no jaundice. So in regard of the ocular exam, external examination, there was no old facial scar of Varicella zoster virus, no lag of thalamus causing exposure or any other eyelid problems, or had rosea facialis like red malor or any acne. In regard for her VA, she had 20-200 OU, and her IUB was 10. And in regard for the pupil, it was round and reactive and no rapid. For the slit lamp examination, her lid and lashes were within normal. In regard for the conjunctiva, in the right eye, it was mildly injected, while the cornea and the right eye had a peripheral corneal ulceration nasally with thinning, and there was no leak, and there was an overlying epithelial defect. And in the left eye was the CDK she was referred to. In regard for the lens, she had nuclear sclerosis, OU, and her EC was deep and quiet, OU. And for the fundus, it was a flat myopic fundus and normal. So our impression that this patient had a right peripheral corneal ulcer with severe thinning. So when we saw this, we thought, is this BUK? Does this patient have an underlying etiology? And this is the first manifestation of such a systematic disease. And is this patient at risk of perforation? So then our differential diagnosis, first, that this is a local infection and infiltrate. And we give her empiric antibiotic for it. And our second differential was BUK, that this is peripheral ulcerative keratitis, and this patient might have systematic disease like rheumatoid, Wegener's, SLE, and polyarteritis nodosa. Or this patient has a systematic infection like TB, HCV, any kind of hepatitis, brucella, or helminthiasis. Or this patient has inflammatory disease like sarcoidosis or IBD. And other differential is this: does this patient has exposure? That's why in the examination we looked for lag of thalamus or any other eyelid problems. Or does this patient has rosea or terine marginal degeneration or Moran's? So in regard for the investigation, since we're looking for systematic disease, we did systematic investigation, like CT chest, PVD, and to exclude TB. And we also did serological testing for infectious diseases like CMV, HCV, brucella, hepatitis B, hepatitis C, Bartonella, and TB. And we also did serological testing to rule out connective tissue disease like rheumatoid arthritis, SLE, Wegener's, and sarcoidosis. We also did Bartonella sinus X-ray to exclude Wegener's, and BAN CT to check for malignancies. We also did ocular investigation, which was corneal scraping and culture, which showed a rare gram-positive foci and few gram-positive visual. So now I'm going to present the management as a timeline. So we have seen the patient at 18th of July with the presentation I just showed you. And we decided to first admit the patient. Then we did corneal scrubbing, and we did all the labs and imaging I just said. Then, since this patient is at risk of perforation, we put eye shield in case of any minor trauma. Then we give the patient prednisolone acetate Q4 hours, Oflux Q4 hour, and we give the patient cyclobentalate TID and doxycycline to promote healing, 100 milligrams BID, and medroxyprogesterone drops QID. The medroxyprogesterone drops also to promote healing, and they were actually not commercially available, so they were prepared in the hospital. And we also give the patient lubrication with Tear Natural and ophthalmic lubrication. So then we time skip to the 4th day of admission. So 72 hours into the admission, the patient is already feeling better. And under the slit lamp examination, the ulcer is starting to heal, and the thinning, and there's improvement of the thinning. And most of our workup showed up negative, especially the BVD and CT excluding TB. And on the 4th day of admission, one of the things that we changed, we switched from Oflux to vancomycin. Since we had the culture showed some growth, just to be extra careful, we switched to vancomycin Q3 hours. And we also gave the patient IV prednisolone 600 milligrams for 3 days. As both the quantiferon and CT were negative, it was safe to give steroids. And in regard for the prednisolone acetate, we reduced it from Q4 hour to QID. And we also gave the patient vitamin D and calcium carbonate, since we were giving her such a aggressive steroid therapy. And on the 24th of July, which was the last day of admission, all the workup of the patient was negative, and there was no evidence of any systematic disease, and the patient was in a stable clinical condition. So we decided to discharge her. And of course, on the last day, under slit lamp examination, the ulcer appeared to have healed, and there was less thinning, and the most important thing, that there was no epithelial defect. It has healed. So, since all the systematic diseases were excluded, this is most likely a Moran's ulcer. So this was our discharge plan. We switched from IV steroid to oral, which was oral prednisolone 22.5 milligrams, taper down 2.5 milligrams every week until the follow-up. And we also gave the patient weekly methotrexate 10 milligrams and folic acid 5 milligrams. And also doxycycline, it is kept for once a day for 1 month. And Bradford QID taper down over 1 month. And the medroxyprogesterone drops TID for 1 month. And we also kept vitamin D and calcium carbonate. And we also gave the patient omeprazole for her stomach ulcer, which could be worsened by steroid. And follow-up were given 1 week later. So 1 month later, after subsequent visit, patient report that she is feeling better. And under the slit lamp, there was quiet ulcer with nasal thinning, but the inflammation has subsided, and there was complete utilization of the ulcer and no epithelial defect. So since we're done with the case, I'm gonna present the overview of the peripheral corneal ulcer. So BUK is basically a peripheral corneal ulcer due to a systematic cause or a local cause. And the pathogenesis is related first to the peripheral. The peripheral cornea is not like the central cornea. It is relatively a vascular zone receiving supply from the anterior ciliary arteries up to 0.5 millimeters. If the clear cornea is also associated with lymphatics, scleral collagen, or tightly arranged thick collagens, and limbal stem cells, which make it prone to such thing to happen, the inflammation. And ulcerative sloughing of the corneal epithelium and corneal stromal melting is the final common pathway of such entity. And the keratitis is to indicate the destructive inflammation that mainly happens at the peripheral cornea because it's relatively vascular zone. And the all the antibodies and the immune system has access to the peripheral cornea more than the central cornea. Clinical presentation, mainly like the presentation of our patient. A patient reports blurry vision, pain, redness, and photophobia. And whenever you say BUK, you should have a differential as we had in our case, thinking, is this infectious? Is this acne rosea or Dillon's or exposure keratopathy or Moran's or terrain marginal degeneration? So sometimes it's difficult to distinguish Moran's from terrain's marginal degeneration, because from differentiating Moran's from BUK is relatively easier. You just exclude systematic cause and local cause. Okay, this is Moran's. But how to differentiate Moran's from terrain marginal degeneration is by not forgetting the classical presentation of terrain marginal degeneration, and there is no epithelial defect in terrain. And you can see, as you can see here, it's characterized by presence of lipid, as you can see, and the training portion is characterized by presence of vascular banus. And both these pictures is for terrain marginal degeneration. And now for the etiology of BUK. For BUK systematic etiology, we divide into non-infectious and infectious. For the non-infectious, we have first connective tissue diseases and vasculitis, like more commonly rheumatoid arthritis, ANCA-associated vasculitis, and Wegener's granulomatosis. There is also polyarteritis nodosa, microscopic meningitis, Stroke-Strauss syndrome, relapsing polychondritis, SLE, progressive systemic sclerosis or scleroderma, and other immune diseases like Steyron, IBD, sarcoidosis. And there were actually some cases that it was related to malignancy. That's why we did pan-CT in our case. It can also be caused by giant cell arteritis. For the infectious causes, it could be due to gonorrhea, TB, syphilis, VZV, any type of hepatitis, helminthiasis, HIV, or Lyme disease. So the approach of BUK in the history, age and gender might help you guide to which systematic disease this patient is having. Presenting complaint, onset, and duration. Usually the complaint is for a long period of time. It's not acute. In regards for medical illness, any of the etiology we just mentioned, you should check in the history if the patient is already diagnosed with such diseases. If the patient is using contact lenses or not. History of TB or contact with TB patient. History of STD. History of acne, which might guide you to rosea facialis, ocular. History of ocular surgery like ECCE, or medication use, steroid, which can guide you this patient might already be diagnosed with a systematic disease. So in regard for the examination, you should first do general examination of the patient, since it can be caused by a systematic disease. Then into the examination, you should check the VA, IUB, the pupil. External exam for any old facial scar or VZV or lag of thalamus causing exposure. In the lid, you should check for myobitis or acne. And in regards for the anterior segment examination, first check for scleritis, as it could distinguish it from Moran's. So you need to know and describe it. And for cornea sensation, and whenever you see the lesion, you should describe it by noting the size, the extension of thinning, and proximity to the limbus, and rule out perforation and infection. And check the EC depth for cells and flare, and look for any iris atrophy. And for one exam for any signs of retinitis or vasculitis, and you should do Schremer's test and tear breakup time to check if there is any dry eye syndrome, as it is one of the differential. And you should always examine the other eye. For investigations, you should first start by doing systematic labs, going CBC, RFT, LFTs, and peripheral blood smears, and serology, as we did in our case. And for imaging, CT chest is important, as it excludes both TB and Wegener's, and you should have CT for the sinuses. And corneoscoping for culture, as local infection is one of the main causes or this is one of the main differentials. And since our patient turned out to be most likely Moran's than peripheral ulcerative keratitis, I'm going to talk briefly about Moran's. So Moran's is basically defined as a BUK without a local cause or a systematic cause. And it was first described by Moran's in 1867. And there is actually two types. The first type mainly affects older adults, unilateral, responds fairly to the medication. And the second type, which is more aggressive, bilateral, and it occurs in more younger population, and it requires more aggressive immunosuppression. History, it mainly presents same as BUK. Although Moran's ulcer is defined as there is no cause, there is actually some precipitating factor like accidental trauma, prior surgery, or parasitic infection. And parasitic infection is a considerable factor because in the research it showed that there is a principal hypothesis that the inflammation due to the infection might alter the conjunctiva and corneal expression of antigen and allow autoimmune response to the eye, causing BUK or Moran's. So this is a picture of a typical Moran's. As you can see here, the peripheral ulceration and thinning, and here also. So this ulceration and how does the disease progress? That this ulceration will keep going, expanding circumferentially and subitially toward the middle cornea. As you can see, this is the same thing for Moran's ulcer, a peripheral ulceration with expansion going circumferentially and toward the middle. And the healing stage of such ulcers is defined as by thinning and vascularization and scarring. And one of the things that helps to identify is this BUK or this Moran's is scleritis, as I mentioned earlier. In BUK, the scleritis is generalized, while in Moran's there is usually no scleritis. And if there is scleritis, it will be limbal scleritis. And one of the presentations, patient might also present with one of the complications like severe astigmatism, perforation following minor trauma, which happens nearly in 1/3 of the patients, secondary bacterial infection, secondary cataract, and glaucoma. So management, always eye shield, as all these patients are at risk of perforation on any minor trauma. And medical management, typical steroid as frequent as 1 hour, and usually taper down over months. Typical cyclosporine, and you can even go for systematic immunosuppression as in our case, as giving systematic steroid, in which they show rapid effect and should be instituted earlier for bilateral disease. Systematic collagenase inhibitors such as doxycycline or acetylcysteine should be given as they promote healing and help in the recovery of ulcers. So in regards for surgical management, conjunctival resection, which may be combined with excision of necrotic tissue, is preferred. There is no response to the topical steroid. The excised area should extend 4 millimeter back from the limbus and 2 millimeters back from the ulcer. So you should take extra 2 millimeters. And keratoepithelioplasty can be done, which is suturing of a corneal lenticule into scleral bed, which help prevent the scleral expansion into the cornea. Of course, steroids are continued post-operatively. As you can see, this is before and after conjunctival resection surgery. Other surgical management, there is lamellar keratectomy, involve the dissection of the residual central island in advanced disease, which remove the stimulus or the cause of the inflammation. Other thing, if the patient, for example, result from BUK or Morans, but want visual rehabilitation, you can offer him lamellar keratoplasty. And in case of perforation, tissue adhesive and bandage contact lens should be done. And this is my references. I went to Kansky, Wills, and the AAO. Thank you. Any questions? Really room for discussion now.
Any question? That means everybody understand what you mentioned. So I have questions for you. It's not actually questions. First of all, if you have a patient with BUK visited to your clinic, what's your definition? I don't like the way that you mentioned, like, you know, terrain and fibrotic keratitis and then like rheumatoid arthritis. How you can organize yourself?
So to organize myself, first, my first question should be: is this microbial keratitis or not? Then, if I kind of isolated that, is this BUK as an entity? Is this Dillon's? Is this terrain? Is this Morans?
What's the best way, in my opinion, to approach any patient with peripheral keratitis or any peripheral disease? Ask yourself, is this ocular or systemic? This is the first question you ask yourself. Then, if it's ocular, is it infectious or non-infectious? Infectious like bacterial, fungal, amoebal, viral. And is this ocular non-infectious? Like, as you mentioned nicely, the marginal degeneration, like exposure keratopathy, and all the other you mentioned, but you throw them all together, which the best way to group them. Right. And then the systemic. So we mentioned ocular, infectious, non-infectious, systemic, again, infectious, non-infectious. Non-infectious, like you mentioned nicely, the rheumatoid arthritis, the regular, the polyarthritis nodosa, the IBD, and then the infectious, like as you mentioned nicely, the STDs and the Neisseria and all other stuff. In this way, your approach will be clean for your differential diagnosis, your workup, your plan, and even in the history taking to start. The general case that will take place on the first slide. The exam-wise. Okay. So what do you mean by VA 2200 OU?
That was the patient VA at presentation, and which did not improve across any follow-up or any other.
Do you think? Go next slide. What's written in the findings?
Flat myopic fundus.
Do you think this is these two VA with flat myopic fundus? There is a correlation between.
Might be. And
what is it?
That her VA due to having myopia.
Exactly.
Or
so tell me, is this a VA without correction or with a correction?
Mm-hmm.
If I don't know, is it because of PUK? Is it because of retinal issue? Is it because of, we don't know, right? So refractive error is not a disease. So we should mention always, if you don't have like facility to do refraction of the patient, do with the pinhole, just to make sure what's going on in the patient version. Go please to the slide. Yeah, the steroid dose. The steroid dose. Give her every weekly. Yeah. Read the first line, please.
Oral prednisolone 22.5 milligrams, taper down 2.5 milligrams every week until the follow-up.
So what we need to mention, is it daily or weekly you give them 22.5 milligrams? And this is very important. We did not.
No, I mean that it's taper down by week. We remove.
I understand. I understand. But we should, لأن الستيرويد doses يعني مثلا بالثيرويد اي ديزيز نستخدم weekly steroid. We don't give daily. So what I will understand here, you are giving weekly to 22.5, not daily.
True.
Okay, so it was given daily.
Yeah.
And you gave the patient Oflux. Why Oflux? Why Oflux? Why not? What's Oflux? What is ofloxacin?
So it's fluoroquinolones ophthalmic drops. It's usually the to go to antibiotic drop in the eye as an empiric therapy.
Okay. So what's the difference? What do you know of fluoroquinolone other than ofloxacin? Do you know any other medication?
I know, but ما تحضرني الآن صراحة. But obviously there are others.
Do you know moxifloxacin? So what's the difference in Arwa between ofloxacin and moxifloxacin? And which one you would prefer in this case?
Coverage.
Okay.
Really, give the extra coverage for this patient so I can go to
Both fluoroquinolone, why the coverage in moxi is more than excellent. And this one is which generation? The ofloxacin. Yes, it's a second. What's the difference in coverage between the second and fourth generation? So fourth generation has more gram-positive coverage. So if you think about MK, you want a gram-positive coverage because it's the most important one.
Yeah, true.
عشان كده انتوا غيرتوا البانكومايسين.
Yeah, true.
طيب, the other question, and for all the group, and this is not for you, just
Yeah.
we're talking about the plan, and I'm not questioning the plan, relax, mashallah, patient to improve, but just if you have a patient, you started them on a wrong medication, let's say Oflox. Oflox is not my best choice because I know maybe we don't have Begamox nowadays. Don't change the medication if the patient getting better. Even the culture say it's resistant, even the culture say it's whatever. If the patient getting better, you don't need to add as long as the patient is getting better, we are happy, regardless of what the medication we are using. Okay. So adding vancomycin in this case, despite getting better, I don't personally, I don't think it's a wise approach here because the patient clinically is getting better, right? Like, tell me 3 causes here of decreased vision in patient with PUK. 3 different. If you have a patient with poor vision, not corrected by glasses, what's your
Patient having severe astigmatism against
excellent? Which type of astigmatism?
against the order. I'm not sure.
Yeah, it could be against the but usually it's irregular astigmatism.
Irregular.
So this is one. Now against the it will get better by glasses. So this is one important differential. What's the second?
Could be to having acute angle closure, glaucoma, secondary glaucoma.
How angular glaucoma will happen? What's the relation between BUK and
I'm not really sure, except for reading it fine.
That's what do you think? What's the other differential of losing best connected vision in patient with BUK?
Astigmatism could be the scarring itself.
So involving the central one. So as long as it's in the periphery, it may induce astigmatism, not much changes. But once it's involve the central, it will cause decreased vision. What else?
Other than the current
Like what?
diseases.
No, retinal disease it can happen to you. It's not related to BUK. Anybody want to differentiate about BUK direct BUK? What do you think? Yeah, could be. But one more common is anterior uveitis. Anterior uveitis is common disease. So if the patient has significant cells or flares, they will have decreased visual acuity. Okay. So keep them in mind whenever you have a freeze patient as a COVID. I have a lot of comments, like let's make them short. for adding systemic medication to your plan, and the discharge medication you gave him methotrexate and folic acid. Why is that? What's the indication of giving systemic medication to a patient with PUK?
Of course, if the patient is not getting better by steroids, you'd go for.
I agree. This is very important indication. Our patient getting better, right?
But she was better when we gave systematic steroid. So we would like to.
No. It's not steroids. Okay. I mean, the discharge medication you give him methotrexate, right?
Yeah.
Methotrexate. Tablet.
Yeah. With
folic acid.
Yeah. With folic acid.
Why is that? What's the indication? Just I'm asking you for the indication of systemic medication for all of your clinics. Anybody knows?
Well, you mean instead of systemic.
If you have a patient with BUK, when you need to, you have to give systemic medication. You have to.
So a case like in cases associated with the rheumatoid arthritis.
This is one. So if you have a systemic disease, this is one. No response to topical measures. Let's say topical measures. So if you did like Provera, doxycycline, lubricant, all of these stuff, no improvement. Another indication. Okay, what else? What's that?
To get to a limit. Steroids being engaged.
Yeah, but when you need to give steroids sparing agent. Certainly, if the epithelial defect is intact, if there is no epithelial defect, and I which want to compress,
We can give
and if the eye is getting whiter, so maybe
we can give them because the steroid sparing agent is the vascular element associated with arthritis and
systemic disease. So systemic disease. Any systemic disease with BUK, systemic medication. We agree about that.
Bilateral disease.
It's bilateral. This, if you have a bilateral disease, systemic medication also. This is also a very important. There is one more. Scleral involvement. If you have scleritis, that means this is not more. If you have a scleral involvement, this is not more. This is not local cause. And why is that, Faisal? You should tell us. Why is that? Why?
I wouldn't know صراحة, but my BUK involves is
What do you think? Okay. Okay, what this more again involved peripheral causes, جنبها scleral. Why not? Have you ever asked yourself? I always ask myself this question. Because the pathogenesis is different. The pathogenesis is different. What's the pathogenesis of BUK? You mentioned it partially.
mainly inflammatory response to the as a part of the inflammatory response to autoimmune diseases. It involves the peripheral cornea because it's relatively.
Yeah, I agree.
Mm.
This is BUK. This is BUK. But what's more? More is a BUK, but the subdivision of BUK more, is it the same pathology?
No, it's not the same. It's more related to antigen expression.
You mentioned that.
Yeah.
And what about arthritis related to BUK problem?
It's more
So which type of hypersensitivity reaction?
like
So in Morin, you have antigen, you have antibodies targeting an antigen in the body. And this antigen is not present in the sclera. This is why we don't have scleritis. And the type of hypersensitivity reaction here is type 2. In BUK, it's type 3 hypersensitivity reaction. So the pathogenesis is different. The involvement is both for sclera and for the cornea. So whenever you see scleral involvement, as mentioned clinically by Etiology, whenever you see scleral involvement, that means you will need to give systemic medication. This is not a local cause. Okay. BUK with scleral involvement. What other indication of? Yes.
have a question.
Sure.
can the patient present with, for example, posterior scleritis, anterior scleritis?
Yeah, this is a good question. Ulcerative sclerosis is different entity. Ulcerative sclerosis usually is idiopathic. Rarely it comes with the rheumatoid or it's like an anterior scleritis. It's the one associated with the BUK. But if you work up the patient with ulcerative scleritis, rarely you will find systemic association. Rarely. Okay. And what's the feature of ulcerative scleritis? How you can see the patient? Do you know? بس بمعنى كان just this is irritating me if you jump to the World Cup without clinic. We are wise. دائما الدكتور حكيم. دائما الحكيم الوحيد هو البيسكان. ما ادري صح.
We do examination of your rocks to see how to watch sport.
Put on sports you see. This is the right. Put on sports you see. There's something written right. I will help him. How you see thinning with ulcerative you need to read the article and then to read the presentation of ulcerative. So, any other question? Sorry.
What do you see?
What do you see right with this scan? You mentioned this scan. Dr. Ahmad asking you what you will see in ulcerative right.
The T sign, the attenuation of the edema causes reverse shadowing.
So there is edema. So what are you looking for other than this kind?
The exam.
And as percent keratitis, what signs or something you look for before doing this kind? And you know there is edema, the is clear causing this shadowing in the T sign. So does it represent anything clinically? Anyone?
Try to give it to the body.
Ah,
Try to give it to the body. By default.
right.
Any other comment? Actually, the last you mentioned in your local measure and at the end of your presentation that we have like in more usual, as you mentioned nicely in the treatment plan, you will go with local measures like you give the patient lubricant, doxycycline, and Overa, which is progesterone, and then you went through the conjunctival recession / resection. There is one important add here. If you want to do any resection of session in patient with BUK or oral ulcer, add amniotic membrane. Amniotic membrane transplant is very important here. And what we do, if you have a patient with BUK, we recess the conjunctiva and then we place a layer of PMT covering the conjunctiva and also we call sandwich technique and also covering the conjunctiva from upside and the downside. So it will cover the whole thing to isolate the antibodies that coming from the peripheral blood vessels from the cornea. This is one technique we can also have in patient who not responding to your local measures, patient with more ulcer. The last indication of systemic medication for patient with BUK is bilateral molar. Even if you have ocular code, which is more, but it's bilateral, you have to give systemic medication. كيف بتعرف انها bilateral molar ما هي bilateral مثلا BUK secondary to systemic disease? You will know it by negative workup plus there is no scleritis. Does this make sense? So whenever you have scleritis, this is not. You mentioned at the end also of your presentation what the tissue adhesive. If you have a perforation, tell me which type of tissue adhesive you use and which type you will use.
Last, I don't know any.
Yeah, I know it's a last question.
Yeah.
Arwa, do you know what are the types of tissue adhesive that you know?
Such cases.
What's that? Good. So, oh, that's good. Yes. What else? What other tissue adhesive you know? So we need to have this tissue adhesive. It's not really that. We need please to prepare a talk of tissue adhesive. I think this is an important one for everybody. The types and indication. But you have this. We should come with very nice presentation. Well done. I wish that if you add pictures, a lot of pictures, and make your font size a bit bigger, not to be a busy slide, it will be better in future.
Thank you.
Whenever you see a button, okay, try to keep an eye on it. It will change the way you deal with people. Only يعني notice that clinically في F2 table changed all the implications that I met after that. For us, clearly I can say this is والله looks ocular or this is system. Whenever you pass by UK, try to look at them. Try to look for it. If you don't, ask your team. Where an edge difference and know is this involved sclera or not? And early on, if you notice that there's no there is sclera involvement or there is not, it will change the way you approach this case. Keep this in mind. Very important.
Yeah. There is a trick. Thank you, Dr. There is a trick. How you will know that there's a sclera involvement? The eye is injected. How are you looking? Right. So what I do, put peroxide eye drops. The pain should subside if it's the pain related to the corneal ulcer. If the pain didn't subside, touch the eye. If the patient jump, this is scleritis. You know what you give. If you put peroxide eye drops, and if you touch the eye, the patient jump, this is scleritis. There is scleritis. So you are not dealing with something local. So you need to consult that. We are not here at the hospital, we have a pathologist. So we should consult with a patient with keratitis for all of this. So we need to take care of, don't take it light. And untreated, and one of the study, untreated PUK is a chronic to systemic disease. The mortality rate in 5 years is more than 80%. So it's not a joke. It's not a joke, please. So make sure that you deal with any PUK. Don't diagnose patient more in front of start. Just try to be for investigation. This is your حتى لو ما في سكليرايتس حتى لو متأكد من شق الهلوك. If you think 1% that it might be systemic, go ahead and do all of your workup and make sure that investigate for any health causes, especially inflammatory or arthritis, and IBD. You have another presentation. That's it. Any other question, Dr. Nabil? Do you have any comment from retina point of view?
I'm sorry. Regarding scleritis, maybe I don't know what you're talking about. Scleritis.
Sure.
Scleritis. Scleritis sometimes it comes as only exudative RE with minimal pain. So not only the choroidal folds. So sometimes you put the patient on OCT machine, you see some subretinal fluid or even exudative RE. The patient is complaining only of mild pain and decreased vision. So one of the first diagnoses in these cases is not to jump to BKH straight away. So it's not BKH. Sometimes it's
Serous keratitis. Even with fluorescein angiography, you might see the same appearance of leakage. So choroidal fold is a good sign, but sometimes it's maybe the collection of fluid that will go under the retina.
Yeah. Actually, this is a good point. Also, if you have a patient with unilateral disc swelling, and there is no APD, also serous keratitis is one of the good differential here. If you have like disc swelling, as Dr. Nabil mentioned nicely, if you have exudative RDs, these usually associated with disc swelling or sort of hyperemic disc, but you will never see an APD on these patients. They will have decreased color vision because they have subretinal fluid, so the color vision contrast will be low, but there will be no APD. This is the trick. And think about scleritis here also. So scleritis is a bit different entity from anterior scleritis. It's a bit different entity, and it's really associated with systemic disease. It's usually like idiopathic. Any other comment? Any other question? You have a question?